Thank you, sir. At the outset, I'd like to thank you for inviting me to be a participant in this very important and prestigious course. I have no financial disclosures. We all know that astigmatism, by its very presence, depreciates the quality of unaided vision in most of our patients. We're also aware that 35% of our patients who come in for cataract surgery have significant amounts of astigmatism. That means one diopter or more. And we know that various modalities are available for correction of this treatment, such as glasses, contact lenses, arcuate keratotomies, excimer laser, and toric lenses. We are also now convinced that amongst all these modalities, it's the toric IOLs that give consistent and predictable results. And yet, when some of my colleagues have taken up to these toric IOLs, there have been some problems that have emerged in their mind. Main thing of this is proper case selection, some little tips as far as the pre- and intraoperative surgical skills are concerned, and how do you integrate this in your common day-to-day practice. Now remember one thing, the basic principle of any toric intraocular lens is that it only corrects the residual post-operative astigmatism. Toric IOLs also only correct regular symmetrical astigmatism. They do not correct irregular astigmatism, and a misalignment of a toric IOL by even 1 degree leads to a 3.3% reduction of its efficacy. Small errors build up into a large error. We start with the promise of making the patient spectacle independent for distance, and we get easily disappointed when we are left behind with a 0.75, 1 or sometimes 1.5 diopters of astigmatism. And we all start wondering where we've gone wrong. Now my job today in this instruction course is try to familiarize you with simple techniques that can be used to avoid these mistakes without the use of some of the expensive instruments. Let us see. First and foremost, remember that if you have a patient with an irregular astigmatism, if you have a patient with a corneal scar, if you have a patient with a progressive astigmatism like a keratoconus or a pellucid marginal degeneration, he is a contraindication for this toric IOL. The first thing that you need to do is determine your own surgically induced astigmatism, ascertain the need for a toric IOL, measure the magnitude of the astigmatism, and we're going to see how important that is, determine the axis of the principal meridians, and mark the reference axis and verify the same on the slit lamp. Now, determination of the surgically induced astigmatism is a must. You must remember that your own surgically induced astigmatism is going to be different from location to location. You may be located temporally, you may be located superotemporally, and you may be located superiorly. Of all these things, the temporal incisions are always inducing the least amount of astigmatism, and the superior incisions always give you the most amount of surgically induced astigmatism. And also, the temporal incisions are most consistent and predictable as to the amount of astigmatism you'll induce. A 2.2 millimeter incision in the temporal plane, for example, with me, induces a 0.2 diopters of astigmatism. But if I were to use a 2.8 millimeter incision, then obviously my astigmatism will be different. So you need to know your surgically induced astigmatism for various locations. And it's not difficult at all. If you start feeding your own results retrospectively and go on to the Warden Hills calculator, it's very simple. The next thing, determine if your candidate or your patient is a suitable candidate for a toric IOL. Now this is an ideal situation. This patient has, with the rule, symmetrical astigmatism and is an ideal patient for a toric IOL. But have a look at this patient. This patient on the topography shows a partially asymmetrical astigmatism. This is his left eye. And have a look at his right eye. In his right eye, he has a totally asymmetrical astigmatism. Now this is not probably a very appropriate candidate for a toric IOL. Contrast this with another patient who has come to us asking for a multifocal option, and this is the astigmatism in one eye, symmetrical, and this is the completely asymmetrical astigmatism in the other eye. Now you have got to be very careful. Therefore, one of the equipments which I think is a must for a toric IOL is your keratometer. You may not rely upon its value, you may not rely upon the K value, you may not rely on the axis of a topographer, but to know the kind of astigmatism before you go in is very important. There are various keratometers which are available in the market to determine your astigmatism. You don't have to buy all of those. Choose the ones which you have, but have at least two. have a manual and at least an automated K. And let us look at it why. What does a K value actually tell you? K values tell us three things. It first gives you the magnitude of the corneal power from the corneal radius that we measure, and hence it gives us the mean K, which is K1 plus K2 upon 2. It gives you the axis of the meridian. Basically, remember that astigmatism is a vector. So if it has a magnitude, it has to have a direction also. And third thing, the difference between the two principal meridians gives us the amount of astigmatism. Now, which value you'll use when? As far as the magnitude of the corneal power is concerned, which you're going to feed in your formula, we are not talking of astigmatism here. Optical biometers and manual keratometers are more accurate as compared to automated keratometers. Automated keratometers, most of them measure at a radius of 3.3, at a diameter of 3.3, whereas the optical biometers and manual keratometers are smaller at 2.3 and 2.8 millimeters respectively. Handheld auto K, however, is very reliable, and topographers are not reliable because they give the simulated value over the entire cornea. As far as choosing the right axis, now this is very important because your incision, your planning, everything is going to depend on the axis. Suppose your axis at which you're supposed to, which you're going to have the maximum astigmatism is going to be 20 degrees, and you enter it as 30 degrees, you've gone wrong by 10 degrees straight away. 3.3% per degree means 33% of your astigmatism went wrong there and there itself. Remember that optical biometers and table-mounted chin-supporting autokeratometers are more reliable as compared to handheld auto K, where your pronation and supination of the hand will give rise to a difference in the axis. Topographers also, again because they measure the thing, over the entire cornea. Now some small tips for reference marking. I don't want to teach you how to make a reference mark or how to put an axis mark. But always do the reference marking in the sitting ahead position. Do not make it lying down so that you reduce the cyclotorsion in the first place. Very often I've seen people struggling to try and put the thing and the patient is blinking away. Don't be afraid, just put in a small wire speculum. This is good for two reasons. It avoids the blink and it dries the cornea sufficiently for you to be able to make the mark. And remember that making the mark, put the mark on the peripheral cornea as well. The mark should cross the limbus and it should be on the cornea as well as the conjunctiva. This is important because the conjunctival at the limbus is mobile and it can move, and your mark will move, but your corneal mark will not move. And once you have done the marking in the sitting position, patient right in front of you, put the patient on the slit lamp. The slit lamp is the best device to know whether you marked correctly. Because all slit lamps, whether you use an Indian slit lamp or an imported slit lamp, have basically an ability to rotate the beam. And at the same time, there is a scale to tell you the axis by which you have rotated the beam. If you have made a mistake when marking in the straight head position, you can recorrect or note the degree of rotation. You might have gone wrong by 5 degrees to the right or 5 degrees to the left, clockwise or anti-clockwise. Make a note of that and put it on your chart before you go into the operation theatre. People ask me, why do you not make the marking on the slit lamp itself? Well, if you're going to do it freehand, it may be possible, but if you're going to put an instrument such as a reference marker, it comes between the patient's eye and the objective of your lens, and it becomes rather cumbersome to put it over there. Now, some golden rules intraoperatively. If you have made the reference marking and you want to make the axis marking later, please make it after you've done the phacoemulsification, because in the presence of a cataract, the patient may not have good fixation. Remove all the viscoelastic behind the intraocular lens. Then you rotate the IOL so that the steep meridian of your lens aligns against the thing, and you should put it in such a way that the axis of illumination is perpendicular to the iris. Seat the lens well within the bag. Make sure that the lens is centered on the visual axis, as Samresh was saying. And immediately after the surgery, take the patient back on the slit lamp and verify. Here you have a patient who is under topical anesthesia, the pupil is nicely dilated. Go back on the slit lamp, check whether you have placed the lens in the right axis. If not, if it's gone by more than 5 degrees, you take the patient back onto the operation table and re-rotate the lens till you have achieved the precise alignment. This one step will improve your results manifold. And this is just to show you how you align the lens along the steep axis of the cornea. Choose a lens which has rotational stability. Do not take a lens where the rotational stability is suspect. You want these lenses to remain for a long time. So choose a lens like this where you can see the result 1 month post-op and you see the result 27 months post-op. The lens is where you left it. Having understood these small things, how do you make these lenses commonplace in your practice? You need to integrate all your staff members. All your staff members need to be educated. All of them should know what is astigmatism and how important it is to correct astigmatism. So they need to be in tune with you and they need to speak the same language as you, so that as the patients keep on speaking to the staff and the staff keep on educating, the patient is tuned to the idea of correcting his vision with the help of toric lenses. Patient education in the form of in-house surgical videos, magazines, as well as handouts is of course very, very important. But the most important thing is the pre-operative counseling. You need to have a good counselor who can sit with the patient, give them demonstrations or show them films where astigmatism is being spoken about, and you need to give the patient plenty of choices as far as the lenses are concerned. Not too many, but if they're going to choose a monofocal lens and they have astigmatism, talk about a monofocal, aspheric and a toric lens and emphasize the difference in that. If the patient is still not convinced, you can probably demonstrate what astigmatism is by putting a cylinder in the other eye which has got good vision, so that they know that if they were not to put a toric lens in the eye, this is the kind of vision that they would get. And let your patient counselors offer a toric IOL option for all patients with a preoperative astigmatism of greater than 1 diopter. Remember, there are no major investments required to implement this technology in our practice. And concomitant treatment of cataract and astigmatism using one simple, safe and dependable technology is something very, very good. The first few toric lenses may be time consuming, but soon you'll become familiar with this technology and learn to do the procedure very efficiently. Thank you so much, ladies and gentlemen.